covering their ears because, they are sensitive to certain sounds, or, they would come and, tightly hold on your hand because they're seeking for some sensation. And medical history would be, did the child cry after the delivery? How much was the birth weight? And family priority. So these are the things that make the therapy individualized. Okay. And how do we get all this information? So as a speech therapist, we do a speech and language evaluation. And of course, the parents comes with a referral letter from either from a pediatrician or a neurologist, and we do an evaluation, a detailed speech and language evaluation, and we get all these information from our evaluation. Now, after the evaluation, what do we do? So imagine after the evaluation, as a therapist, I found out that the client's primary issue is he's not able to use the oral muscles properly to make a sound clearer. For example, I noticed that after the evaluation, the child is not saying ooh. The child says, if I say, can you say ooh? The child would do ooh. There is no enough movement of the lip for the child to make that sound correct, right? At that time, speech therapy will focus on oral placement therapy. Okay. And I have taken something, tools to show you. So this is one of the tools that we use in oral placement therapy to help the child round their lip to say the sound oh. So we keep it between the lip and we slightly, give a slight pressure between, on the lip to make this lip go round. Okay. This is one of the therapy method that we do. Now, after the evaluation, we figured out the child's primary concern is the child is not chewing properly, or he's not taking few texture. We do feeding or swallowing therapy. Okay. Now, after the evaluation, the child is just 2.5 or 3 years. Uh, we do early intervention, right? And that would look like that we would be running around in the room. It's more play and fun, and there'll be a lot of bubbles around, and parents would be in the session and we educate the parent, we train the parents. That is early intervention. Okay. Now, after the evaluation, we figured out it's more stuttering. The child say b for banana, or mama for mama. So speech therapy will focus on fluency. All right. Now, I'm saying all this because I want you to understand why the speech therapy looks different for each child, okay? Now, after that, again, after the evaluation, we figured out the child has a lot of nasal sounds, or some sounds are mostly come through the mouth, because there are some nasal and oral sounds. So child has issue with that, and we focus on that. That is where the voice comes, okay? Now, after the evaluation, we figured out child says tat for cat. The child is unable to, or let's say he says banana for banana. That time, the therapy would focus on articulation, okay? And after the evaluation again, we figured out the child's pragmatic skill is not appropriate. He does not initiate a conversation with adults or peers, or he does not maintain a conversation. He does not wait for his turn. So that time, the speech therapy will primarily focus on social and cognitive communication, okay? And there is also something called AAC. I'm sure you've heard of it, augmentative and alternative communication. This we do it in speech therapy to boost the child's communication skills. Okay, so to answer the first question, why speech therapy does not look same for each child, that is because we do an evaluation, and we find out what is the primary concern of the child, and the therapy will focus on that. Okay, now, please feel free to let me know if I'm going very fast. So you can just drop it in the comment box. I can go slower. Okay. The next topic is why progress may appear slow even when therapy is working. Okay, there are several factors that influence the rate of progress. So I've taken 3 key points. The first is prerequisite skills. And second one is state of the child. And third one is environmental factors. Okay, let's look into the first one. Okay, so what is prerequisite skills? So prerequisite skill is a skill that you require to learn another skill. To make it very simple, for me to get a driver's license, I need to have a good steering control. I need to know the signs on the road. I need to have a good judgmental skills. I need to have good decision making skills. Of course, I should know parallel parking and 90-degree parking, and I have to give a test and get a license, right? So those are the prerequisite skills for me to get a license. So now we work on prerequisite skills. So now this graph, if you see, I'm going to give you a scenario. Now imagine, let's take 5 children. They all have come with the same diagnosis. And let's say they are all 5 years of age, and they all enrolled in therapy at the same time, and same number of therapy and same duration of therapy. Now, after a month, typically what we expect as a parent, we expect if let's imagine, see, look at this, the first one, the child A. So this is the baseline. Okay, so this child's baseline before he took therapy, his baseline was no word. So as a parent, what do you expect? You expect the child to go at least to pointing level, right, after a month of therapy. Now, the second child's base level was pointing. Now, after a month, what do you expect? You expect the child to at least to begin use single words. Now, what if the baseline was only single word? Of course, you expect the child to use short phrases after a month of therapy, right? This can happen. I'm not saying this will not happen. This is what we usually expect, because as a parent, we always look into the visible progress. 0 word, pointing, 1 word, 2 word. This is what we always expect, right? Now, when I talk about prerequisite skills, I'm just gonna give you one more slide. Sorry, one more graph. See, if you see, you can see 2 different graphs, right? The first one has strong prerequisite skills. The green shade that is here, we worked on the prerequisite skill. Okay, this is the week of therapy and this is the progress. Okay, so if you see the graph A, you see the green shade, that is strong foundation skill. On graph B, we did not work on the foundation, or we did not work on the prerequisite skills. And what happened to the progress? The orange line is the progress and green line is the prerequisite skills. So if you work on the prerequisite skills, the progress is drastic. But during the initial days of therapy, as a parent, you won't see a visible progress, because you won't see the child going from no words to pointing or pointing to 1 word, because the prerequisite skills are mostly the invisible progress, we can say, because it's mostly building attention, or like if the child was no words to 1 word, we work on attention and concentration or sitting down. So those are the prerequisite skills. So imagine I did not work on the prerequisite skills. So what happens? The progress is almost plateau, you can say, or there is no considerable amount of progress. Now I'm going to give you example of a therapy-based example of what prerequisite skill is going to look like. Okay. For articulation. So imagine I have a child whose the sound p is not clear. The child is not able to say the sound p. Okay, and I'm working on that. What could be the prerequisite skills? Of course, a child should be able to move the lip, right? The lip is the articulate that we are going to use for the sound p, right? And for me to use, so it's easy for us because it's p, it's easy for us. For a child who has an issue for saying the sound p, the child should be able to dissociate the lip from the jaw. That means we don't say pa like pa, or we don't say pa like pa, right? We say pa. We know how to move our lip independently without moving any of the parts of our face, right? But we see children, they would either do pa or they will either do pa. So it's either over movement or there is no movement. When I said over movement, it's not a right word. But I was trying to say the child uses the jaw or other articulators. The child is unable to move the lip independently, right? So what we have to work on. So I want the child to move the lip independently for him to say the sound p, right? The prerequisite skills going to be, I will work on the strength. I will work on improving the strength of the lip, right? I will work on improving the range of the lip and rate of the lip. And only then and I will also, because pa is a pressure consonant. If we say pa, it's not pa, it's p, right? So strength is of course important. So we need to work on those prerequisite skills, and only then the child will be able to say the sound pa. And the child being able to say pa is a visible progress, right? But other things are not really visible. So if I don't work on the lips strengthening or lips range or rate of the movement, the child will not be able to say pa in let's say after 10 sessions. Or but if I work on the prerequisite skills, the child will be able to say the sound pa eventually. Okay, same thing even for reading. For example, for a child to read a sentence, he should be able to know what could be the prerequisite skill. The child should be able to know the letters. The child should be able to know what does a letter make, like the b, the letter b makes the sound b, or the c makes k, right? The awareness of sounds, and the child should be able to blend those sounds, and he has to have good auditory attention and discrimination. The child should be able to differentiate between p and b, or t and d. And also, he should have a good orientation. He should know I should read from this side to this side, not from this side to this side, right? And also visual tracking. He should know where did he finish, where is the full stop, right? And also the comprehension. The child should understand what he read. So these are the prerequisite skill. Only if you work on auditory attention, memory, and blending, the child will be able to read. Okay, those are the prerequisite skills. So that is what the graph shows. Once you build on the prerequisite skills, the progress are drastic. If you don't work on the prerequisite skills, the progress is going to be sloppy. Okay. Now, the next one, the state of the child. So internal processing, it's mostly the attention and processing. So understanding of spoken language, interpreting instruction, organizing thoughts before responding, retrieving words from memory, planning a motor or verbal response. And emotional readiness would be willingness and emotional safety. Of course, the child should be able to, and also feeling safe with the therapist. The child should be able to open up, and he has to be comfortable with the therapist, right? And being open to interaction. And how is he dysregulated? Is he crying in the session? Is he being hyperactive? Does he shut down between the session? And how is his health? And is he motivated for session? So all these are the factors that will affect the speech therapy session. Now, I am going to show you two videos, okay? And this video, there's no sound in this video. It's just uh, two sounds. So I want you to guess what sound is it. You can either unmute and tell me the sound, or you can put it in the chat box, okay? And I will play the video and I will wait for, let's say, 10 seconds, and then I will go to the next video. So you have two videos with no sound, but I want you to guess what sound is it, okay? Are you seeing the video? Is it playing? It's playing on my side. Can you give me a thumbs up if it is playing? Okay, yeah, okay. I think it's playing. I see the messages. Okay. Okay, the next video. I'm going to go to the next video. Okay, can you tell me or type it in the chat box which sound I hope there was no video. I unmuted. I mean, the video was on mute. I hope you didn't hear the sound. Okay. Okay. It wasn't that difficult. Okay. Someone says ma. All right. Now I'm gonna play the video again with the sound.
Him. Louder!
So the first sound was p, the letter P. And the second sound was
B says. B says.
it was b. Okay, so the first sound was p, the second sound was b. And why I did this video. So it's because even as adults, we find it very difficult to process an information completely without having enough cues, right? Because on the first video, it was only visual. There was no auditory input. And I'm sure some of you might have struggled, whether it was pa or ba or ma, because they all look the same, right? The mouth moved the same almost. So what we are trying to say is, also, I'm sure you have had this experience in your life. You might be there could be someone speaking to you for a long time, and then later you will be like, what did they just say? I mean, you didn't process anything that they said, right? I am married, and I know, like, I could be talking to my husband for like 5 minutes, and I would ask him, and then he would be like, huh. So it happened to me. So imagine a child in the class. So he could be sitting there, he could be present, physically present, and he could be hearing the teacher saying all these sounds, like, let's say, letters. And his brain may not be fully available for that kind of attention, or his attention is still developing. So he may not be able to process the per as per or per as per or ma as ma, right? Because the attention is still developing, the processing is still developing, he might not be able to differentiate between these bilabial sounds. And what happens at the end? So this particular child may develop reading, writing issues or speech sound, issues. So, so the thing is, performance depend on access to cues, attention filters information, and processing gives meaning. Okay. Now, the next point, environmental factors. So other intervention or therapies. So which means a child comes up to me and I'm doing sessions with him, and I realize the child is not holding the pen properly. And of course, we refer the child for occupational therapy, right? So is the child attending the required sessions that or intervention that he needs? The consistency of session, is the child attending sessions regularly, or is he canceling the sessions? And parental involvement, are they involved in the therapy sessions? And limited opportunity to use targeted skills socially, which means generalization of skills. Was the child able to use, let's say the child learned give me, and was the child able to use give me in different occasions? And peer pressure or embarrassment. So regarding this, I've had cases where, so let's take the case stuttering. So uh, imagine the child learned fluency shaping methods, and when we try to you do a small group session with the child who has stuttering, because he's had experiences where, I don't want to say bullying, but the children could be asking, why do you speak like that? So he would still have that pressure, even if the child learned a fluency shaping technique. When he's enrolled in a group, he would still have that peer pressure, and that would bring his stuttering, like the anxiety. And sleep patterns. Did the child sleep well before the session? Or diet and nutrition, was the child fed well? Did he eat well? on general health and wellness. Okay. The next one is importance of generalization and consistent practice beyond session. So what's the generalization? The child uses the learned skill with different people in different places and situations. So without home or school practice, learning stays therapy only. Skills do not transfer. Progress appears slow. Children depend heavily on prompt. And with consistent practice, faster independence, more spontaneous communication, better retention, and reduced therapy duration. That's all we want. We don't want child to be in therapy forever, right? The next topic is why may children perform differently in therapy, class, and at home? Okay, so therapy is mostly one-to-one, of course, and it's a predictable routine and reduced distraction. Expectations are clearer. The therapist structures the communication. No sibling or peer pressure. Visual supports are provided. The therapist waits intentionally and gives space. I'll explain more, okay? In school, it's usually busier, more demanding, socially complex, too many sensory distractions. Classroom demands affects processing, less individualized interaction, but it's a part of learning, you know. That's why we put the child in the school, right? Home, familiarity, habits, and sometimes depends on adults. Adults anticipate that kids' needs quickly. Routines are predictable. Caregivers unknowingly fill in the blanks for the child. Okay. Now, regarding this, um, have you noticed? So, whenever you send your child for therapy, of course, the child is screaming for a few sessions, and then they will get used to it. Of course, we are so good. We build the rapport, and the child is very comfortable with us, and eventually they do so well in therapy. That is the one reason for that is it is structured. The child is already mentally prepared to come to the session, right? For example, when I go to school, we deal with even KG, like pre-KG and KG children. They used to cry, you know, like because they don't know what's going to happen. But after few session, they're mentally prepared. They know she will come and take me after my recess. So the child is already prepared. He's already informed about the speech therapy and he's already prepared about speech therapy. Now, what happens at home? I know you all are working and we come home, we do our chores, and then, you know, and you see your child is playing, and then I'm like, okay, let me do some speech class with my child. Let me do some reading with. So he could be playing Legos, he could be watching something, or he could be doing something interesting for him. And then you are like, now I am free, let me do speech class for you, or let me do some reading for you. The child is not going to cooperate with you. He might sit with you, but he might not be fully interested or motivated to do the session that time. So what you can do is you can prepare a routine for a child. And when I say make a routine for a child, I don't mean 8 o'clock, swimming, and 8:30 eat, and 8:45 speech. It's not like that. Try to have an activity constant before you do reading or before you do speech kind of activities with him. So he's ready. Like, for example, if you do speech class after every Lego time, so imagine your child has a Lego time, he plays with the Lego, and for a week you do speech, your reading or your whatever activity your therapist told, if you're doing that at home after the Lego time, you have to inform him, of course. You should tell him, after the Lego time, you're going to do this. And he might not cooperate initially, like let's say 1 or 2 days, and then he is already prepared. The child is already prepared. After the Lego, I will do this reading or whatever with my mama, and he will cooperate with you. Trust me, you have to just do it. So it could be difficult for the first 2 days, but after that, he's ready. After Lego, it's speech class, it's reading time, I'm gonna do with my mama. So you can try doing it that way. That will, also reduce your headache, because we don't want the child to scream at you also, right? And another one is role of adults without creating dependency. So I don't want to say LSA because I've had instances, like I've seen even parents go as an LSA or even nannies go as an LSA. So I'm just going to use the term adults. So we are going to discuss about how to use LSA support without replacing a communication, how to set up opportunities for independent communication, how to give the child time to respond, how to fade prompts gradually, when not to prompt, when not to over prompt, and prompt dependency. Okay. And I am going to give you a couple of examples, and I am sure you will understand all these after those examples. Okay. So the first one, um, imagine I have a child sitting with me and I have the LSA in my session. Of course, we explain the LSA or the mom, whoever it is, an adult's with me. And of course, we explain the person sitting with the child, this is what I'm going to do with your child. And, this is how you introduce this goal. This is how you fade the prompt. So now my goal was to teach the child to independently request to say, Miss Arya, please open the door. Now, what I do, I take the child, I go near the door, and of course, I have to lock the door. There should be an intent to communicate, right? A motive to communicate. I lock the door and I go stand opposite to the child. So this is a new goal, okay? This is something new that I'm doing in the session. So I'm showing the adult, this is how you fade a prompt. So my goal is I want this child to say, Miss Arya, please open the door. I go there, I take the child's hand, I tap on me, I take the child's hand, I make him tap on me, and I say, Miss Arya, please open the door. And child will say, Miss Arya, please open the door. I wait for 3 seconds and I tap again and I only say, Miss Arya, the child will say, Miss Arya, please open the door. Third time, I wait maybe 10 seconds. I only tap. I take the child's hand, I tap on me, and I wait. And it could go two ways. One, the child will say, Miss Arya, please open the door. Well and good. The child said it, the child said without any help, and I will open the door for child. And if he's still waiting, the child did not say, Miss Arya, please open the door. What I do step one again. I tap, I take the child's hand, I tap it on me, and I say, Miss Arya, please open the door. He will say, Miss Arya, please open the door. I wait. I tap. I say, Miss Arya, he will say, please open the door. Again, I will wait. I will only tap and I wait. So what do I expect? I want the child to say, Miss Arya, please open the door. If the child doesn't say, I will wait until the child say, Miss Arya, please open the door. You will have to do the same thing, maybe 5 times, 6 times, 7 times, until the child says, Miss Arya, please open the door independently. I don't open the door. And of course, I don't make a scene where the child is angry or frustrated. We know how to tackle them and we make it really fun. So I did this in the session. I showed how to fade the prompt very well because, if you keep giving verbal prompt, it's very difficult to fade. But if it is physical, so if you see the third stage, I was only giving a physical prompt. So this was a prompt for the child. I tap, then he knows, oh, I have to say, Miss Arya, please open the door, right? So it's easy to fade. But if you keep giving the verbal prompt, it's very difficult to fade. So I did this in my session. And session was over and I said, okay, bye. And I told the person was sitting, the person that, can you also make him say, please open the door when you go? And what she did, they closed the door and she's like, what do you have to say now? That's wrong. I never said that. I never asked a child, what do you have to say now? What do you want? Okay, say this. I never said that. I clearly showed how to model and how to fade that prompt, right? But I don't know, somehow that is quite tricky for the LSAs or the adults sitting with the children. They tend to ask this question, what do you want? What do you have to say now? Make a full sentence, all these are a prompt. So it could be a little difficult for you also to understand. We are training the child's brain in a way that I go near there and I look at this person, they give you some kind of clue. It could be a question, it could be a fill in the blank sentence, anything. But And then I ask, the child already knows how to open the door, but he will just wait only if this person says, what do you have to say now? So that is prompt dependency, right? We don't want that. This is one. Another example. I had a student sit with me, and I did all the prerequisite skills. I hope you remember that, for recalling an event. Okay, I did all those in my previous session. So today my objective was, I asked this child, okay, what did you do in the class before you came for the session? So I expect the child to say, I did this 1, 2, 3, 4, 5. So I was giving him time. Meanwhile, the person who was sitting with the child said, wait, what did you do before you ate strawberries? What did Miss Stanley tell you? So I'm like, no, it's a prompt again, right? So we don't replace the communication. You can model them. You know what you can do, you can show them, Miss Arya, I did this 1, 2. You can act as a child, you can tell this therapist what you did, and the child will copy you. Another example, this is the last one, I promise. Another example, we also do this observation in the classroom. And okay, this is not to degrade anyone. I'm not blaming, I'm just trying to say these are the mistakes that we often see with the person who is helping the children. So when we go to the classroom, what we usually see is, we keep the LSA with this child to make the child not to depend on him, rather to make him independent in the classroom, right? So this teacher is giving instruction, and this LSA who is sitting with the child would be like, example, the teacher said, open to page 145. So what, as an LSA, what you should do is, you should help the child listen to the teacher, not repeat the instruction. So the LSA, what they usually do, they goes like, can you please open the page 145? That is wrong. So what you have to do, you have to make sure the child listen to the teacher. You can, if the child doesn't listen, or if you have a lot of options. You can make the child sit next to the teacher, or you can prompt the child to stand up and raise the hand and say, can you please repeat? Because we have a lot of options for that, but we do not want the adult sitting with the child to repeat the questions for the child. You have to make the child listen to the teacher. Okay, so i I hope you understood when I meant how to how to use LSA support without replacing. I hope all these questions are clear with all these examples. If not, now we have question and answer. Now we have the discussion time, and you can ask me the questions, and I'll be happy to answer. Not just about that, anything. I mean, I think it came out just about the LSAs, but anything that you had doubt, you can ask me, then we can discuss. We do have other speech therapists here, so we all can have a discussion, or anything is fine. You can either unmute and say, or you can put it in the chat box. Oh, I think the meeting was so good. There's no questions. Thank you. Was it that clear? Oh, I'm so happy if it was so clear. Or was it like when I said, this processing, and I was talking to you, and I don't, you didn't process anything that I said? I hope not. I tried to make it interactive, but yeah. Oh, I see a lot of well done's and insightful. So I think there is no questions. I'm just gonna wait for some more time in case if. Even if you feel the questions are silly, you can, you know, hop in. I mean, okay, if there is no question, then we can wind up the meeting.
Thank you so much, Arya. It was really helpful, and I think parents can really benefit from all the notes that you've mentioned. So thank you so much.
You're welcome. Thank you. Okay. In case if you come up with some questions, you can always reach us at Indicare Health Center. We'll be happy to help you if you have any questions or. Okay. So I wind up the meeting. Thumbs up. Okay. Thank you. Bye, everyone. Have a nice evening.